right, everyone, thank you for calling in. We're going to go ahead and get started with our webinar about LARCs. And Dr. Berlin and Joe, do you want to take it away?
Sure. This is Elise Berlin. I am a proud member of the Ohio American Academy of Pediatrics chapter. I am an associate professor in pediatrics at Ohio State, and I am the director of our Young Women's Contraception program at Children's called BC for Teens, as well as the physician leader for the overall hospital's teen pregnancy prevention efforts.
And my name is Joe Taylor, and I am a family nurse practitioner that has spent the last 18 years or so in the area of women's health and mostly contraceptive management. Currently, I am a full-time provider in the Women's Health and Family Planning Center at Columbus Public Health right here in Columbus.
All right. Both Joe and I are Merck clinical trainers, and I think that's the only disclosures that we have. All right. Well, Joe and I have split up this presentation, and I'm going to kind of go over the first 3 bullets, and the roadmap looks like this. We're going to generally talk about the use of LARC and other contraceptives in the United States among adolescents. I'm going to describe to you what are the variety of IUDs and the contraceptive implant in terms of indications, side effects, mechanisms, and length of use. We'll go over some recommendations for their use in adolescents and young adults. And then Joe is going to review IUD and implant myths that we know are pervasive and interfere with or play a role in decision-making around contraception. And then Joe's going to share some really great practical tips to improve LARC use in your practice and make it more teen-friendly. All right. Well, if you're on this webinar, you probably know what is meant by LARC. LARC is a term that refers to long-acting reversible contraception, as well as long-acting reversible contraceptives. You'll kind of see it used both ways. A new terminology is out there, and some qualitative research suggests that this is more acceptable to young people, which is using the terminology of low-maintenance contraception. And really the idea is that teens maybe kind of put off hearing about how long something works, but really kind of framing it as low-maintenance, maybe a terminology that's a little bit more well-received in teens and young adults. So when we talk about LARC, or low-maintenance contraception, what we're really referring is contraceptive implant, and the current one that's available is called Nexplanon. And also in the category of LARC are IUDs, and there are hormonal and a copper IUD, and we'll review the hormonal IUDs that are available and the copper IUD during the presentation. So I'd like to start off this conversation really talking about kind of what's going on with our young people and sexual activity in the U.S. currently. And according to the most up-to-date data from the CDC Youth Risk Behavior Surveillance Survey, or the YRBS, which this is the 2015 number, about 41% of adolescents in high school in the U.S. report having had sexual intercourse at some point in their lives. And really this number, for those of you who might be thinking, wow, that's a pretty low number, it really is. It has declined since it was about 54% when the survey started in 1991. So we know from this data and other pretty validated data that reports of teen sexual intercourse have been on the decline for some time in the U.S. The one other part, I'm going to just go back to that slide real quick, if I can, Kaylee. The part about that number, I think that's important, is that doesn't just apply uniformly. So certainly there are populations that are more sexually active, and we also know that as adolescents' age that they are much more likely to become sexually active. So if we look at ninth graders in high school, it's about 30% report sexual activity in the past, and that's intercourse. But then if we look at high school seniors, it's closer to 2/3 or the majority. So good to know that as teenagers age, that they are approaching time when they're more likely to be sexually active. Thanks, Kaylee. So one of the unique characteristics of teen birth in the U.S. Is that compared to adult pregnancy, where about 50% of pregnancy is intended and 50% is unintended, when we look at teen pregnancy, about 80% of the pregnancies are unintended. And then if you bring up the next couple bullets, I really think there's a couple different ways to think about this. So of those who had an unintended birth, of those teenagers, were queried back about their contraceptive use at the time of conception, 48% of those who had an unintended birth were not using contraceptives at the time of conception. So really there's room to just increase contraceptive use all around. But 52%, so even more than that number, were using contraceptives at the time of conception. So to me, this really illustrates the need for both wider access to any contraceptives, as well as a focus on using contraceptives that are less prone to failure, the more effective contraceptives. And when asked at the last sex what type of contraceptive they used, 43% reported that they did not use a condom. All right, next slide. And the bullet, yep. And then this is really surprising. Okay, so 43% no condom. And then this is out of the Youth Risk Behavior Surveillance Survey, looking at folks who reported being sexually active. At the last time they had sex, 73% reported no use of birth control pills, patch, shot, ring, implant, or IUD. So essentially a hormonal method or a copper IUD. And then when we looked at the number who used both a condom and a hormonal method or a modern contraceptive method, you can show the next dot, Kaylee. It's about 9% used a dual method. So 91% did not use both a condom and a pill, patch, ring, implant, or IUD. And for those of us who take care of adolescents regularly, this is not particularly surprising, I think, but it really, again, illustrates the room that we have for improvement in the U.S. with both condom use as well as access to modern contraceptives. And then kind of finally the money slide, kind of what proportion of females who are using birth control in the U.S. Are using an implant or an IUD. And the number is really low. The number is about 4.3%. And there's two large data sets that were queried recently and came back with similar numbers. And this number has not changed particularly much since the last version of this study. What we have seen is that there are some age populations of adult women who have definitely increased use of LARC, but adolescents still really underutilize LARC and have not been seeing the increase in LARC use like adult women have. All right, and this is a piece of research that was done by a colleague of mine named Elise Carbanda, and she's in Minneapolis. And what she did is she did a large database query looking at this large pediatric group's primary care visits in the last 12 months. And so these were all adolescents seen in a large group, commercially insured, and they looked at those who had a positive pregnancy test, and they found that on average there were 2.7 primary care visits in the 12 months prior to becoming pregnant. So I think this really shows that as pediatricians, we definitely have the opportunity to make a difference in the lives of the young women that we see and the girls that we see, because they're in our offices, and really we can do more to help them prevent pregnancy. All right. Well, if you were sitting in an audience out there, I'd ask for a show of hands for those among you who have heard about the Contraceptive Choice Project. But I can't do that, so I hope some of you have heard of the Contraceptive Choice Project. This was a large cohort study that was conducted in the St. Louis area starting in 2008, and it continued through 2011. It was funded by the Susan Thompson Buffett Foundation. And next slide, please. The aim of the study was to really, kind of frankly, to increase LARC use in the area. And then the person that they tapped to do the study really said he wanted to really make it very scientific. So they created what we now know as the Contraceptive Choice Project, and the rationale for the study was that they wanted to eliminate access and cost barriers, and they did this, and this is before the ACA and kind of the contraceptive mandate. So they actually provided whatever method, reversible method that the participant wanted at the time of the study visit, as long as they were medically eligible, so really eliminating access and cost barriers by doing it in one visit. They provided a brief counseling that focused on efficacy, and then they trusted each participant, each woman, to pick the method that best met her unique needs. And what they found has really changed the world of family planning as well as OBGYN family practice and pediatrics. And I'll show you what they found in the next slide. So the study enrolled slightly more than 1,000 adolescents, if I recall. And I know from talking with the study investigators that they thought if they had really 5 or 10% of their adolescent participants pick a LARC method, that they would be very surprised at the time. And what they found really shocked them. They found that 69% of the 14 to 17-year-olds in the study picked a LARC method, and the younger adolescents were more likely to favor the implant versus the IUD. And then when they looked at the 18 to 20-year-olds, they found that still a majority, or 61%, also picked a LARC method. And in the older young people, we saw that they did favor the IUD more than the implant. In addition to showing that adolescents and young adults are interested and will pick a LARC method, they also found that the LARC methods were associated with the highest rates of satisfaction and continuation compared to all the reversible methods that were offered. And they showed that there was an 81% continuation rate of the LARC methods at 1 year compared to 53% of those who initiated a non-LARC method actually discontinued. And furthermore, they showed that young people and adolescents had the same rate of continuation as older women at 1 year. So here they've showed that they really do desire and will pick the methods if they're getting the information about them, and they're very satisfied, and they tend to continue them longer than the other methods. And then finally, that they are not surprisingly more effective than the combined hormonal methods. So they came up with a number that the LARC methods in the study were 20 times more effective than combined hormonal methods. And then when they looked at the whole kind of teen cohort, so not just adolescents who picked a LARC method, but just looking at kind of having a choice, having access, what kind of difference did that make? They found that the teen birth in the Choice Project was 1/5 of the national rate among teenagers, and also that the abortion rates for people in the Choice Project were less than half the regional and national rates. So really this project really started a lot of people really thinking about how can we counsel adolescents and young adults about contraceptives, and really pointing out the importance of really offering all methods and using an efficacy-based counseling approach so that people have the opportunity to make that informed choice. All right, and kind of finally in this vein, this is another recent study that came out of Adolescent Clinic in New York City that was published in JPAG in 2015. And what the authors of this small study in an adolescent clinic found was that in real life, compared to the IUD, other methods, which were depot, pill, patch, and ring, were 6 to 12 times more likely to be discontinued than the IUD. And the 6-month discontinuation of depot was 80%, the pill was 57%, and the patch and ring was 83%. Another thing that they found, and I don't have a bullet point for this, but the study found that young women and girls who wanted an IUD, who had to get rescheduled to come back for an IUD, had a lot of loss of follow-up. So also really thinking about how can we provide access at the time of visit. So I hope the last slides that you've seen have suggested to you that there are really many missed opportunities to provide valuable services and care for adolescent girls and young women. Birth control pills and condoms are the most commonly used contraceptives among adolescents, but pills have high failure rates, and so do condoms, and pills have high discontinuation rates. LARC use, unfortunately, remains low and hasn't budged very much, and I think, the call is for all of us healthcare providers is that we can do better to serve our patients in the communities that we work in. And if you can push the next bullet. So, why are we talking about access to LARC, particularly in a pediatric setting? So, these methods are out there. They work very well, for contraception. And bringing up these methods really does add value to the interactions that you have with your patients, because if they don't hear about them from you, they really might not hear about them from anybody. And you know this as well as I do, that, if you have an adolescent in for a visit, you might not see that patient if they're an otherwise healthy young person for another year or 2 or 3. So really thinking about taking advantage of the opportunities we have and adding value to that, and making it, in the next bullet please, and really kind of making it patient-centered. Next slide. All right, so now I get to go through kind of the laundry list of societies that really have endorsed LARC use for adolescents and young adults. So I'm just going to go through these slides. So you're probably not surprised to know that the Centers for Disease Control medical eligibility criteria, and actually I should point out that there is a new 2016 series that's been updated since the slides were submitted, has, for the duration that it's existed, really not found any eligibility concerns for adolescents. And so for the implant, there are really no restrictions by age. And for the IUD, they're a Category 2, which indicates that the advantages generally outweigh the proven or theoretical risks. And ACOG has stated in their committee opinion that LARC are safe and appropriate contraceptive methods for most women and adolescents, and as well that provider concerns about LARC use by adolescents are a barrier to access. Society of Family Planning as well says that adolescent women should be considered candidates for IUDs. And then finally, our American Academy of Pediatrics, in their contraception policy statement about 2 years ago, came out with the recommendation that LARC are recommended as first-line options for teens. So we don't need to wait for them to fail. Another method that we should really be presenting information about contraceptive methods in an efficacy-based way with LARC as a first-line option. All right, so we're going to talk about a case that will help us kind of walk through the different contraceptive options that we have that are in the LARC category. So Aisha is a patient who comes in. She's 15, and she presents to your office with her mother to discuss contraception options. She has heavy periods with lots of cramping, And this is a true patient that I had, and you've probably had some like this. She tried pills for a month, experienced nausea and worsening headaches, and then forgot to tell her mother when she ran out of her pack. So she was literally in the office with me talking about kind of her pill taking, and her mom at that point realized that like she was not actually taking her contraceptive. Next slide. She is sexually active. So this is kind of how I framed it with her. Aisha, I'm so glad you're here to talk with me today about birth control. It sounds like you had a rough time with the pill. The good news is that there are some extremely effective options available to you. What I'd like to do would be to tell you a bit about your options, starting with the most effective, okay? All right, and this is a slide that shows you what a menu of contraceptive options looks like that is efficacy-based. This is what we call our menu of contraceptive options here at Nationwide Children's Hospital, and we've really modeled this off of the Choice Studies contraceptive menu that you can find online if you look up LARC first. This is also similar to some of the World Health Organization menus as well. Next slide. All right, so the first method we're going to talk about is the etanogestrel implant. This is the only contraceptive implant available in the United States, and the current version is called Nexplanon. Nexplanon is a small, thin, implantable, progestin-only hormonal contraceptive that's effective for at least 3 years. And I tell my patients and their families that this is the most effective hormonal contraceptive on the planet. It is 99.95% effective. The primary mechanism of the etanogestrel implant, or Nexplanon, is suppression of ovulation. So it really is a mechanism that is used in many other contraceptives that we have. And it's inserted under the skin in the inner arm using a local anesthesia. And this is a very fast procedure. It takes me less than 2 seconds to place the Nexplanon. So really something that's practical for office setting for pediatrics. So the main counseling point, I would think, or I have found in my practice, is to really counsel on the bleeding side effect of Nexplanon once you have someone who's interested or who wants to learn more about all methods. So the bleeding is unpredictable on this method, and that's the wording that I use with my patients and their guardian or parent if they're there. I tell them that many women have fewer days of bleeding, but about a fifth have more, and it is just completely unpredictable. They might not have periods at all. They might have a couple weeks here or there. One of the interesting things about bleeding with Nexplanon is that the first 3 to 6 months of use's bleeding pattern really does generally predict the bleeding pattern for the duration of use. So with some of the methods such as Depo and pills, we may counsel about irregular bleeding, but usually provide the reassurance that it's going to get better. With Nexplanon, it may get better, but really the bleeding that's irregular in the beginning certainly may continue through the duration of use. And the bleeding is really the primary reason for early discontinuation. Nexplanon does not appear to affect bone density, and none to minimal weight gain has been associated with Nexplanon, and certainly none in a causal way. And this is a study that we just published this spring. We did a chart review of 750 patients that had received an Nexplanon or Implanon at Nationwide Children's Hospital, and we found that about 10% discontinued the Nexplanon or Implanon within 1 year. So, this is really consistent with kind of data about adult discontinuation, and we were happy to see that. And again, bleeding problems were the primary reason in this pediatric population for early discontinuation. So when I'm counseling a patient and obtaining informed consent for Nexplanon placement, I review the benefits. It's highly effective. It lasts for 3 years. It's reversible and safe. The main side effect is the unpredictable bleeding, and I do, emphasize the point that this bleeding is normal. This method doesn't protect against any sexually transmitted infections, and the potential complications of insertion include pain, infection, bleeding, scarring, tissue damage, and migration. The next method I'm going to talk about is the 52 milligram levonorgestrel IUD. There are two devices that are 52 milligram levonorgestrel IUDs. That's the Mirena and the Loletta. The Mirena is a 5-year device, and the Loletta is a 3-year device, and we'll talk about that in a couple slides. These methods are these devices are small, flexible intrauterine devices that are really very small and release 20 micrograms per day on average of levonorgestrel. The primary mechanism of the hormonal IUD is the thickening of cervical mucus as well as inhibition of sperm motility and function. And there are also likely some effects on the endometrium. Next slide. So the one that's a 5-year, that's approved for 5 years is the Mirena, and that's the one that probably most of y'all are familiar with. This method is 99.8% effective in the first year of use, and it also carries an FDA approval for use for treatment of heavy menstrual bleeding in women who seek contraception. It has been found to reduce menstrual bleeding significantly by 90% in the studies or clinical trials to gain that approval for heavy menstrual bleeding. So it really can have a very nice effect for women who have heavy menstrual bleeding as well as cramps. Next slide. The Mirena has not been found to have any effect on bone density or weight. I counsel women that they may have some cramping as well as irregular bleeding for up to 6 months. And another consideration is that many women will ovulate while on Mirena. So if you have a woman who has some other kind of perimenstrual symptoms, such as mood changes, acne, etc., those considerations may impact your choice of a contraceptive. The Loletta is a 52 milligram levonorgestrel IUD as well, and this one is 99.4% effective in the first year of use. It is FDA approved as a 3-year method. However, the Loletta is really contains the same medicine dose as the Mirena, and I understand that the company is going to kind of look to extend the duration of use as their clinical trials continue. So the idea is eventually this is going to be a 5 or even potentially 7-year levonorgestrel IUD. It was FDA approved in February of 2015, and this device has an approval for use in nulliparous females. This is a very inexpensive method. The cost, as an example, for institutions that have 340B pricing is $50 to $60, and it's made by Allergan Ad Medicines 360. There is another IUD available that is about a quarter of the dose of the Mirena and the Loletta. This one is called Skyla, and it's 99.1% effective. This one also has an FDA approval for nulliparous females and is effective for 3 years. This one has a little bit more bleeding than Mirena due to the lower dose of levonorgestrel in the method. And finally, we have a copper IUD. In the U.S., we have the Paragard, and this one is 99.2% effective in the first year. It's effective for at least 10 years, and it's also FDA approved for nulliparous females. It's also a very effective emergency contraceptive. One consideration around Paragard is that women may have heavier periods and increased cramping, certainly in the beginning and possibly for the duration of use with Paragard. A real benefit, though, is that it's hormone-free, and it may be a really nice choice for someone who either has medical reasons that she cannot use hormones or personal preferences. So you can really offer a very effective hormone-free method for her. So this is an example of the informed consent for Mirena. The benefits of Mirena are that it's highly effective, it lasts for 5 years, it's reversible, it's safe, and it reduces menstrual bleeding. primary side effect is that users may have cramps and bleeding or spotting for about 3 to 6 months, and it certainly doesn't protect against any sexually transmitted infections. Potential complications from an insertion include infection, bleeding, pain, perforation, and expulsion. So back to our case. Aisha is very interested in the Nexplanon. She reports her last intercourse was 6 months ago. Her insurance is Ohio Medicaid, and her urine pregnancy test is negative. And since you know that many young women do not return for their LARC placement, you decide to go ahead and start the Nexplanon in the office today. So Aisha tolerates the procedure well, and she and her mother leave assured that an unintended pregnancy is extremely unlikely. All right. I'm going to end with a slide about how to get Nexplanon training. So Nexplanon providers, so anyone who orders, the ordering physician or healthcare provider, or the person who does insertions and removals, is required to be formally trained by Merck. And the website is here. If you're interested in going on, you can kind of put that into your browser. And you can add your name at the request training site, and then they will contact you when there's a training in the area. Only clinicians who have completed the training are eligible to purchase the product and do the procedures. And the clinical training program is available to U.S. clinicians as well as advanced practice clinicians and physicians. So what can you do? Well, first of all, you're on this webinar, so thank you for being here and educating yourself. I'd encourage you to continue to educate yourself as to the devices, as well as what are the opportunities in your community and who can you link with to help your patients get access. You can certainly get trained to place LARC. You can provide accurate information to the teens and families you interact with, and we'll have a slide at the end that has a bunch of websites with really good information on. Absolutely encouraging abstinence and condom use, and encouraging conversations with parents and guardians and the young people that you take care of. Encourage the use of contraception, including LARC for sexually active teens, and then helping teens access and connect to LARC services. All right, and with that, I'm going to hand it over to Jo.
All right, thank you very much, Dr. Berlin. It's a great honor to always work with you and be presenting alongside of you. And let me start by saying that despite the fact that we've heard that there are solid and consistent recommendations regarding LARC use from many bodies, including ACOG, the CDC, and the AAP, and there really is good evidence to support that teens and adolescents that use LARCs have good outcomes, patients, parents, and even some clinicians still have concerns over their use. Now, some of these ideas are based on misconceptions and myths. Some of it comes from previous devices that were on the market quite some time ago and later removed. And in my experience, I found that a lot of this inaccurate information can really be addressed through the counseling and education. So you'll see here on our first slide that myth number 1 is a very prominent myth that still is out there, and that's that LARCs can cause pelvic inflammatory disease and infertility. So where does this myth really come from? There were IUDs in the past, such as the Dalcon Shield, that were associated with significant problems. That device in particular has been off the market for over 30 years due to a flawed design that was linked with septic abortion, infertility, and PID. We now know, though, that today's IUDs are not associated with these same risks, and that the primary cause of PID and infertility is chlamydia and gonorrhea, and that information comes directly from the CDC. Also, the World Health Organization looked at 23,000 IUD insertions and found that the risk of PID was the same as a woman's baseline risk. And actually, the IUDs that contain progesterone, such as Mirena, Liletta, and Skyla, like we just saw, may actually provide some protection against PID due to the thickening of the cervical mucus that can happen. It should be noted that there's a slightly increased risk of PID in the first 20 days following an IUD insertion, just from the actual procedure itself. And as we heard, LARCs are reversible. ACOG tells us that once removed, a woman's fertility rapidly returns to her baseline. And the return to fertility usually happens within about there's actually been pregnancies reported within about 3 months. There was a study in the International Journal of Fertility that found that 61.5% of women got pregnant within that 3-month period following removal. And that was also found in Contraception, where they saw that over half of women conceived within 3 months following IUD removal. And with the implant, once removed, the hormone level is virtually undetectable after 1 week. And in my own practice, I've seen a positive pregnancy test within about a month after removal. So it's very fast. How does this relate to practice? Counsel patients on their actual risk, encourage consistent condom use to prevent STDs, and screen routinely per the CDC guidelines. Okay. And then myth number 2 is that LARCs cause ectopic pregnancies, and this too is false. The facts are that LARCs are exceptionally effective at preventing overall pregnancy rates and thereby reduce the overall ectopic pregnancy rate. The evidence shows IUDs reduce the risk of ectopic pregnancy to 1/10 that of women not using any form of birth control. And with implants, ectopic pregnancies resulting from method failure were similar to that occur in the general population. Also, in terms of having a patient having had a previous or past ectopic pregnancy, that is a Category 1 as far as the U.S. MEC criteria for IUDs and implants. And so Category 1 means there are no restrictions on use. Okay, next slide, please. Okay, so the third most common myth is that LARCs, IUDs, and implants are too painful and that teens and adolescents will just not tolerate the insertion. The truth is there aren't many studies that look specifically at adolescent pain and IUD insertion. However, those that are out there are quite reassuring. So Brockmeyer et al. Reported that 33% of nulliparous women found insertion to be less painful than expected, 45% the expected level of pain, and 19% more painful. There's also a literature review of 12 studies between 1996 and 2014 that looked at adolescent young women and nulliparous women, and the majority of those participants reported IUD insertion pain as described at a moderate level. It's also well established that pain decreases over time with IUD use. And as Dr. Berlin noted, as far as the implant goes, we use a local anesthetic, which is very well tolerated. So implications for practice, education is key. It's also recommended a vocal local. Sometimes you'll hear that referred to as Verbicaine. That's recommended. This is sort of the practice of verbal reassurance or talking someone through a procedure. And in some studies, that's been shown to be as effective as local anesthetic. And in my own experience, that works very well with teens and adolescents. Also, slow, deliberate actions, especially when you're inserting or managing IUDs to reduce pain. And then support through the initial period over those first 3 months as teens and adolescents get accustomed to their new method so that they can get some reassurance from you as far as maybe some cramping or bleeding and things like that. Next slide, please. Okay, myth number 4 is that IUDs are only for women that have had a baby in the past. So this myth and this belief is especially restrictive and can create many barriers for patients. The facts are that IUDs are U.S. MEC Category 2 for nulliparous women, and that category tells us that the advantages outweigh the risk. And as we saw earlier, according to ACOG, intrauterine devices may be inserted without technical difficulty in most adolescents and nulliparous women. Some clinicians also ask about expulsion, and from ACOG we know that the intrauterine device expulsion rates range from about 3 to 5% in all IUD users. And in adolescents, it's 5 to 22%. However, they also tell us that young age, previous expulsion, and nulliparity may slightly increase the risk of expulsion, but that this current research is limited and that these factors should not be considered a contraindication for another IUD provided that appropriate counseling is given. Next slide. The next myth is that LARCs can only be inserted during a menstrual period. And this is very common. We still hear this one quite a bit. According to the CDC, an IUD or an implant may be inserted at any time if it is reasonably certain that the woman is not pregnant. And these guidelines that you'll see there come from the Selected Practice Recommendations for Contraceptive Use. This is an excellent resource. It's one that I really use routinely in my practice, along with the U.S. medical eligibility criteria that Dr. Berlin mentioned earlier. There was also an analysis of this criteria through the Contraceptive Choice Project. So they created a checklist using this criteria along with a negative pregnancy test. And what they found were that those two things together, they were able to safely exclude more than 99% of early pregnancies for the purposes of contraceptive initiation. This can also be found in the Journal of Contraception from 2015, and it's listed on my reference page. So this can offer providers a lot of reassurance and help to avoid delay of insertion in most patients. And in my own practice, I'll tell you that just like we saw from our case study today, I quick start all implants, and I use these guidelines along with a negative pregnancy test in terms of determining if someone can have an IUD on the same day. So using these guidelines and quick starting implants, there are very few patients that need to return for a second visit, which, like we heard earlier, many patients will kind of drop off and not follow up. Next slide, please. Okay, myth number 6 is that serious side effects are common with LARCs. In terms of side effects, patients and providers alike seem most concerned about perforation. And the fact is, with IUDs, perforation is still relatively rare, approximately 1 in about 1,000 IUD insertions. Some sources will even list it as less, more like 1 in 2,000. The literature tells us there are no significant differences in perforation rates between nulliparous and multiparous women. And with implants, changes in the menstrual bleeding pattern is the most common side effect. I also like to point out that during counseling, when you're going over some of these risks, I think it's also important to remember and to point out and highlight the non-contraceptive benefits, such as treatment of dysmenorrhea, as part of the education and informed consent process. Okay, so the next myth is that teens prefer birth control pills and not other methods, including LARCs. And Dr. Berlin talked about this earlier. The Journal of Adolescent Health reported that more than 50% of young women thought positively about IUDs after being educated on them. And when cost was removed as a barrier, adolescents are more likely to choose LARC over other methods. So this really backs up what the Contraceptive Choice Project found. And the facts are that adolescents desire long-term birth control coverage. However, they're not always familiar with LARC or where to get it. These are methods that are, once inserted, they're hidden, they're private, they require no maintenance, such as picking up pills from their pharmacy or returning every month for a depot shot. And so it really is that low-maintenance birth control that really fits with teens' lives quite well. And in my own practice, the contraceptive implant is by far the most popular method among teens. And so next, I would just like to talk to you a little bit about ways that we've incorporated LARCs into our practice here. In my own clinic, almost half of the women that desire contraception leave with a LARC, and most times it's on the same day. And really, this is a dramatic improvement from where we were about a year ago. So I want to share some of the interventions that have worked for us to create more of what we call a LARC-friendly culture or environment. The first thing is to speak LARC. So all of our staff members, from the front desk to the nurse, maybe the medical assistant that rooms the patient, to all of the providers here, receive LARC training on a regular basis. And everyone is able to provide really a comprehensive LARC education. We also track the LARC data, so we track how many patients come in for birth control, how many of them leave with a LARC. We look at how many of it is, is it on the same day and things like that. So it's really an ongoing conversation that we have, and we really consistently strive to increase the number of LARCs provided. And sometimes we talk about it in terms of infant mortality, teen pregnancy rates, and things like that to get everyone really excited and engaged. Next, all of our patients are offered a LARC. So even patients that report that they're very satisfied with their current method are offered an IUD or an implant, and LARC education is reviewed at every visit. And what we found is, even though someone reports, I'm not having any problems on my current method, or I'm happy with the pill that I've been on for the last year, it's very common for patients, especially teens, to switch from a pill or depot to a more long-acting method once they receive that education and learn more about what their options are. We also use evidence-based LARC-first counseling and a menu of choice, very similar to the one that you saw earlier, with the top-tier methods, those of the most effectiveness listed first. Patient education, we focus on a review of benefits and side effects up front. We use many different tools to educate patients, a teach-back method, written materials. We find that teens really like to manipulate or touch the devices, so we, of course, let them do that. And we use materials that are geared toward teens and adolescents. We are big fans of Bedsider, which is, you'll see it in the references list, but it provides a lot of information and education on different methods. It does definitely promote LARCs, but it does it in a way that is very teen-friendly. We also talk a lot about sharing and anticipating specific teen concerns during counseling. So we talk about things like sometimes teens will say, I don't like the idea of a foreign body, and so we'll talk about ways that we can help them think that through. Maybe it's in terms of, well, a piercing that they have or something like that, or maybe 5 years is too long for me. You may hear something like that. So then we focus on this birth control that you're going to use or that you want to use is just for the length of time that you want it for, and focus on the fact that it's reversible. And for that can be very empowering for teens. A reproductive life plan, this is one of the biggest keys to our success. It guides our conversation and teaching, and all patients receive that. Basically, that's planning when will you become pregnant, what will your family look like when you're ready to have one, what other goals do you have that will impact that. We commonly use one key question, which is what do you plan to become pregnant in the next year? And we find that that's a very quick way to kind of guide conversation and different methods. We consistently work to reduce barriers. We try to minimize the number of visits. We try to minimize wait times. We remove any unnecessary or unneeded testing, and we work hard to dispel the myths that we're talking about today. We also take walk-ins for method starts, including LARC. And then in terms of follow-up and support, our health center has added an RN staff position. We'd really like to have that person do more in terms of follow-up with patients after they have a LARC inserted. We have triage guidelines for patients that call with an issue following their insertion of an IUD or an implant, and we'd really like to look more at patient satisfaction and continuation rates, among other things. Next slide, please. And then here are some other ways that we found to help promote a LARC-friendly environment. The first suggestion is to work with your billing staff and payers to troubleshoot any billing issues. There is a great resource available online entitled Intrauterine Devices and Implants, A Guide to Reimbursement. And it's on my reference page, but it comes from ACOG and the National Women's Law Center and other organizations. Like I said earlier, we always have ongoing staff training. I would recommend that you use pharmaceutical companies for training. They have models. They will give you kits. They provide a wealth of information both for providers and also a lot of really great patient education materials. There are free resources that you can get for your office and for your staff from the CDC, such as the select practice recommendations that I referenced earlier, the USMEC, there's Wheels, and there's smartphone apps. There's a lot of really great tools that way that you can use every day in your practice for quick reference. It may be helpful to develop practice protocols, and for providers, you can seek out hands-on training opportunities. And then if LARCs are brand new to your office, you might consider a LARC pilot project, just with some measurable outcomes so that you can build on success. Maybe start offering one method, such as implants, and then build on that and offer other methods. We also use outreach and social media. We like to talk about our successes, let the community know about the services that we offer. It's very common for teens and adolescents to not know where to go to find these services, or to be concerned about cost, things like that. Strengthen your referral network. We work with other community providers. We want to create a very soft handoff process. That's one of my suggestions. And then use your resources, whether it's something that I've outlined here. We have lots of very good local experts. There's great resources online that you'll find in the references. And then my very last piece of advice is just to keep it simple. Streamline the process. If you make LARCs a part of your everyday practice and language, then they just become that part of your everyday practice. Don't overcomplicate it with multiple tests or appointments. Just keep it simple. So that's kind of my final bit of advice and really what's worked the best for us.
Great. So we can open it up to any questions. I'll just go ahead. I have one question that came in on the questions tab, so I'll do that before I unmute everyone. So the question that I got on the webinar was, can we get more info about Quick Start Nexplanon?
Yeah, so the reproductive, so I'm going to point out the kind of bulleted information here. Both, I can't remember the best Quick Start if it's in the reproductiveaccess.org or in the arhp.org, but within those websites there are very handy PDFs that you can print out and hang in your office or kind of put in your protocol binder. But kind of back to where Joe was reviewing how to be reasonably certain that a woman is not pregnant. Really, I think we have kind of moved away from really thinking about calling it Quick Start and just framing kind of the start of all contraceptives that, as soon as you have excluded a pregnancy, that you can start the method. And then the additional consideration is emergency contraception if it's needed. But kind of to sum up, there are some downloadable PDFs of formal Quick Start methods, and there's also the just how to be reasonably certain a woman's not pregnant, and then kind of moving forward with that.
Great, thank you. All right, everyone, I'm going to unmute you, so if you have, just go ahead and speak up.
Well, in the absence of questions, can I? There's been an update since our slides were posted as well. Kaylee, can I go ahead and share one little update?
Sure.
Okay, so both the updated 2016 medical eligibility criteria and the CDC's selected practice recommendations for contraception, which really go through so many day-to-day situations and how to manage bleeding and how to rule out a pregnancy and how to determine eligibility. They are both now available in one app for both iPhone as well as other phones. So if you just go to the App Store for your phone and you search CDC and contraception, it's a very user-friendly app that's been really updated since 2006 or 2016. I'd encourage everyone just to have that and kind of share that with their colleagues.
I have another question that came through on the webinar, and it was a follow-up to the Nexplanon question. And she said her question was about getting Nexplanon in our office for same-day use. Currently, I thought it had to be prescribed or shipped to the physician.
Nope.
Nope.
Yeah. Joe, do you want to answer that one?
Sure. You can order directly from the manufacturer and have them on hand for any insertions that you may need to do. And that's how we do it. We just keep a stock in supply on hand so that we're ready to go. And you can contact the manufacturer, and they can help you order that directly. So once you go through your training, you'll get a special number that's assigned to you, and they just order that. They order it through your number, kind of a thing, so that you don't have to write a prescription. It doesn't have to be assigned to any specific patient, and then you're able to have them in stock.
Okay. I don't know if you can hear me.
I can.
Yes.
Okay, awesome. Hi. I'm Aurora Rivendale. I'm a resident at Grace Hospital. I had a quick question about copper IUDs and adolescents and how you talk about the mechanism of action, since that's like a pretty common question.
Yeah, I think the way that I talk about it with, my trainees and patients is really that the copper gets in the way with kind of the sperm's function and doesn't allow conception to happen. And I think the science is that it's still a little bit unclear exactly what's happening. So I think I don't think we're able to be more detailed with patients other than the copper ions just really create an environment that doesn't favor, the sperm functioning well.
Okay, that's helpful. I think previously it was that people use like, oh, it's creating a hostile environment and irritation and all these things, and that sometimes turns people off. So,
sure. Anytime you call someone's uterus hostile, that might not be good.
I don't tend to do that, but
yeah.
All right. Thank you.
Mhm.